Okay, so first I'd like to thank Michel and Afsaneh for inviting me to speak about our experience for the past 10 years in Paris with our cohort of 1,000 HS patients. My conflicts of interest, our learning objectives. First, the microbiology of HS lesion that was already outlined. Then which antibiotics should we use? Then why, how, and when surgery should be combined with antibiotics. So the plan is simple, why and how. Why prescribe targeted antibiotics? Because of the microbiology and because it works. I'll try to show you. How to prescribe antibiotics. We'll go through all stages and the different indications, and we'll insist on suppressing triggering factors, which is not known in the literature, but it's very important to us, and the prevention of relapses, which drives us to biofilms and surgery. So first, why antibiotics in HS? You have to have germs in these lesions. Yes, of course, contrarily to what was taught in the past for many years, when you perform prolonged culture, you isolate within 4 to 7 days, not 48 hours, an opportunistic commensal flora in all lesions, in all patients. Our team could identify 2 microbiological profiles. One is monomorphous, and observed in 50% of early stage 2 lesions. It's mostly Staphylococcus lugdunensis. It's the red bar. And at times it can be P. acnes, and it's the black bar. So that's only half of stage 1 lesions. All the other lesions, that means the other half of stage 1 lesions, and stage 2 and 3 lesions, are composed of a polymorphous anaerobic flora with mainly Prevotella and Porphyromonas, but also aeroanaerobies such as actinomycetes and Streptococcus milleri. And this result we confirmed by bacterial metagenomics. So we are saying it works. We need first to define what is it works. It's a clinical remission. And these criteria were actually brought to me by a patient 10 years ago. She did automedication for 11 months, and she put herself into remission with antibiotics after 35 years of continuous severe disease. And she taught me what is remission. So on the patient side, it's complete disappearance of pain and draining. And on the physician side, it should be a complete disappearance of inflammation. It means she taught me that if you use the right antibiotics, the edema and the fibrosis literally melts, the erythema faints, and the draining stops. And these are a few examples of what our team calls clinical remission or complete remission. This lady had 20 years of evolution of a stage 2 HS in all areas. This gentleman, he's the same here, had a stage 3 in left buttocks and perineal area for 11 years and 7 wide excisions. This gentleman here, this gentleman had 29 years of evolution of a stage 3 in his right axilla, right groin, and right buttocks. And so you see before and after. So, of course, these patients get sequelae such as multi-pore comedose, epidermal cyst, sebaceous tunnels, and soft and dry skin folds covered with non-inflamed skin. But these shouldn't be counted as active lesions. They are sequelae. Next, so what did we do? We have the target, the bacteria. We have the objective, putting the patient into clinical remission. So what did we do? We had this hypothesis that that the host had some kind of immune deficiency in the skin, and that these bacteria, his own microbiome, would become invasive because he couldn't clear his microbiome from the dermis that it shouldn't be in the first place. So could we, by targeting the microbiological flora that we found, put him into remission? That's what we tried. So Olivier Join-Lambert, who is the microbiologist working with me since the start, since 10 years ago, put out the combination of rifampin, moxifloxacin, metronidazole, and we had an induction treatment for stage 2, and stage 3 patient of ceftriaxone IV. And so in this first retrospective study, you see that our primary judgment criterion was clinical remission. You don't see any study taking this primary judgment criterion, but we had to do it. And so we had a population of 28 patients, 10 Hurley 2, 12 Hurley 3, and you see that we could observe 16 out of 28 were in remission. All stage 1 patients were in remission, and 80% of stage 2 patients were in remission. But you see this strategy was not optimal for stage 3 patients. They were improved, but not in remission. So we'll come back about that. So next we did a prospective study on 28 severe Hurley stage 1. And again, the primary judgment criterion was clinical remission, this time at month 3. And you see that we had 21 out of 28 patients that were in remission at month 3. And within a year, we had 27 that were in remission. You see that they were quite severe, and the median number of flares per year drops from 18 to 1 flare per year after 3 months. And you see that the median sartorius drops down from 14 to 0 and stays at 0 during the year under maintenance treatment. Next, we did a prospective study on Hurley 2, 17 Hurley 2 patients. Again, the primary judgment criterion was clinical remission at week 12. And you see the results. 11 out of 17 were in remission at week 12, and 14 in total during the year. And you see that median sartorius drops down from 30 to 0. Median number of flares per year from 24 to 0. Visit 2 is month 3 or week 12. And the number of areas involved from 3 to 0. But there are bad news. There is a but. There are relapses. When you look at patient, not at patient, but at lesions in the patient, they had 71 lesions. 48 lesions stayed in remission during the year under maintenance treatment. 14 lesions relapsed once and were cured by medical treatment of relapse. But 9 lesions in 4 patients relapsed more than once. And so those patients, they need to go for surgery. Next, you remember the first study I showed you, this little diagram. We were bad with stage 3 patients. We didn't have nice results. So that's why Olivier proposed to have an induction treatment with IV ertapenem in severe patients for 6 weeks. And this time, the primary judgment criterion was improvement of sartorius between day 0 and week 6. So we had 13 Hurley 3 and 17 resistant Hurley 2. And you see that the median sartorius dropped from 49 to 19 at 6 weeks. What was the most dramatic to us, and I first didn't believe this, it was the pain level on a visual analogic scale from 0 to 10. They had a median level of 6, and at 6 weeks, it went to 0. And they tell that they stop their morphine. So if you ask me what is the best anti-pain treatment, it's a correct antibiotic. And this is an example. Of course, stage 3, they have stage 1, stage 2, and stage 3 lesions. So this gives you an idea of 2 nodules that literally melt after 6 weeks of ertapenem. This is what it can do to stage 2 lesions. And it takes a little longer, and they are bigger, they have more germs. Remember, it takes longer for stage 3. So with this information, how actually right now do we treat our patient? We have one important thing is that we observed, we isolated triggering factors. We have 3 triggering factors that we have to deal with, and in our hands at least. When you don't suppress these triggering factors, it is very hard to us to put our patient into remission. When we take care of them, it's easy. So it's diabetes. You need to detect. You find a lot of them, and you need to balance it. But it is also systemic, which is not known, non-steroidal anti-inflammatory drugs and systemic steroids. And if they forget that, they will flare not during the treatment, while they're in maintenance treatment. They will flare within a week, usually, after stopping this treatment. We, of course, encourage weight loss, and it helps. And we tell them it's bad for their health to smoke, but they don't quit smoking. It doesn't really bother us because we put them into remission while they all smoke. So what do we do with Hurley stage 1 patient? Remember, it's the more common stage, so it's really important to take care of them. We divide the stage 1 patient in 2 kinds. We have the stage 1 patient that have less than 5 flares a year. When we stop triggering factors, because sometimes they are loaded with non-steroidal anti-inflammatory drugs, like they take them 20 days a month for painful period, for HS pain, for headaches. You stop that, you don't give any treatment, and they come 3 months later, they had no flares. Of course, no treatment, you just tell them to keep avoiding those triggering factors. If they still flare, we only treat them a few flares a year. We only treat them when they flare with topical antiseptic, or if they're happy with that, or oral antibiotic. And for this mild stage, probably any antibiotic would work. We like to use pristinamycin for 3 weeks, 2 to 3 weeks. And if it doesn't work, we add metronidazole after 2 days. So this is a group that's real easy to take care of. But you all know that we have continuously active stage 1 patients. And these ones, they really need the treatment. And we think they need an induction treatment, purple, a consolidation treatment, and most of them probably need a maintenance treatment. So again, we divide them into 2 groups. If they have less than 5 nodules, we introduced rather early in our strategy this light strategy, and it works with less than 5 nodules. But if they have more than 5 nodules, usually it does not work. So then you have to do the tri-therapy, induction with the 3, and consolidation with rifampin moxifloxacin 4 weeks, then maintenance treatment with cotrimoxazole or cycline. What we like to insist on is for moxifloxacin, you should, before starting it, have an electrocardiogram to make sure that they don't have cardiac contraindication. And please, please, please stop metronidazole after 6 weeks. Otherwise, you will get into neuropathy. You may restart it later on after 4 to 6 weeks of stopping, but don't go over 6 weeks. For stage 2 patients, it's the same strategy, except we have an induction treatment with ceftriaxone IV or IM and oral metronidazole for 3 weeks. And then the same strategy stopping metronidazole after 6 weeks, consolidation for 6 weeks with rifampin moxifloxacin. And between month 3 and month 6, you get a fair idea about which area is or are going to resist or relapse. And then you don't want to keep them relapsing, and using more potent antibiotic. You send them to surgeon. Stage 3, it's about the same philosophy, except they have more germs, more resistant. So the induction is different. We use ertapenem for 6 to 8 weeks through a PICC line that we insert during a 1-day hospitalization, and then try therapy for 6 weeks, then biotherapy for 2 months. We make it longer because it's bigger lesions. And then between, I'd say, 4.5 months to 6 months, you get a pretty good idea of which area is resistant or relapsed when you stop metronidazole. That's a big test, to stop metronidazole, and you see which is going to relapse. And then for each time we send them to surgery, we re-intensify treatment. And for stage 2 and stage 3 patients, we give them IV, ceftriaxone and metronidazole for stage 2 and ertapenem for stage 3, 2 weeks before surgery and 1 week after. This way, lesions are very much cooled, and it's really easier for the surgeon and the patient to heal and to work. So why do they relapse, and what is the solution? We have already almost pretty well gone through this. What we observed during the past 9 years that we have been using maintenance treatment is that they only relapse in scars. So Olivier, like 7 years ago, told me, I know what it is biofilm. And we're very pleased that answering this year confirmed the presence of biofilm in scars. So the problem is that antibiotics are not active against biofilm. So if you save the biofilms, you will save the relapses. So what is the solution? Surgery. You treat the relapse, but then it's surgery. And so we made it a rule that after 2 relapses within 6 months of remission, we send them to surgery. So in conclusion, targeted antibiotherapy can lead to remission in a majority of patients. The problem is not to put them into remission, but it's to keep them in remission. So this beneficial effect can be prolonged under a light maintenance treatment to prevent relapses in association with localized or wide excision, depending on the severity, in order to limit prescription of wide-spectrum antibiotics. Efficacy and tolerance of a targeted antibiotherapy, such as we are using, it still needs a randomized controlled trials, and we would be happy to conduct it. So future treatments should probably combine, and I completely agree with Jocelyn, several options, including biotherapy, and we were discussing this with Michel yesterday. We could probably have the remission faster with combining antibiotics and biotherapy. The idea is to, of course, spare the use of wide-spectrum antibiotics. And these are the takeaway messages. Microbiology of HS lesions, as you see, correlates with Hurley stages and guides the choice and length of induction and consolidation treatment with antibiotics. Triggering factors must be suppressed, and surgery must be combined to targeted antibiotherapy in order to limit resistance. And I'd like to thank my partners in crime, especially Professor Joan Lambert, who is the microbiologist, Professor Alain Ovnanian, who is the geneticien, and Maya Delage, who is the clinician, and the patient that teaches everything to us every day.